of how that mechanism works. So with that, I'll turn it over to Katie.
So as Laura's saying, the Pain Neuroscience Education Plus is what Evidence in Motion, the International Spine and Pain Institute calls their program. So everything that I'm talking about today was things that I had been educated on through this certification.
Can you guys hear Katie in the back? I know. I need to turn it a little bit so you're projecting that way. Will it turn?
Yeah, last time I did it, it just unplugged. So. Better? I'll try to be louder. Alright, so what is pain neuroscience education? So evidence indicates when a clinician explains the neurophysiology of pain, and when the patient is able to understand this, that they have less pain, less disability, increased function, improved participation with rehab, and have better cognitions in regard to pain in the nervous system. And this is from Adrian Lau, and that is who has started this pain neuroscience education program. So typically we've been treating pain through a biomedical approach. It's what us therapists typically do. We focus on anatomy and physiology, and we have just seen that that's just not quite working for our chronic pain patients. So the biomedical approach focuses on anatomy and physiology. Disease and injury can be explained based on how our structures are abnormal or differ from the normal. So treatment of the structures should therefore result in normal function and elimination of symptoms. And this approach has kind of taught patients to sit in our office and expect that fix me approach. Sit down, what are you going to do to fix me? And we know that this approach isn't working for chronic pain, because if you think about some of the people that I've had patients sit down in my office, maybe for a shoulder injury, and I look at their hands and are terribly arthritic and have no pain at all. So showing, we know that people have abnormal structures without pain and normal structures with pain. Okay, so a typical pain misconception that we are kind of taught in school a little bit with the gate theory. So when a part of our body is injured, we don't have a special pain receptor that is sending pain messages to our brain. So we'll kind of go into a little example on this. So if I walk out the door today and sprain my ankle, based on the importance of the situation, there's not a whole lot going on, I'm probably going to have pain in my ankle. And from my ankle, the nerves are going to send a message up to the spinal cord, to the thalamus, to the brain, saying, hey, take a break, go sit down, take off your heels, limp a little bit, and it'll get better. But if I'm walking out in front of this busy street and sprain my ankle, if I limp and stop, I'm most likely going to get hit by this bus. So do I experience pain, limp, and get hit by the bus? So ultimately this shows that pain is going to determine, the brain is going to determine whether we have pain or not. What is the biggest threat to the body? So if tissues were what sent pain messages to the brain, then all injuries would hurt, and then things like this, more life-threatening injuries would occur. So the brain decides the greatest threat. So this is a little diagram to help show from Louis Gifford how the brain interprets pain. So we have input from the tissues. So this is nociceptive messages, so danger messages that come up from the nerves to the spinal cord, and then we get inputs from the environment as well. So this could be whether the environment is positive or negative. An example is in a game, if the team is winning the game and an athlete gets hurt versus losing the game. Also work environments versus if you are satisfied with your job versus not being satisfied with your job have an impact. And so these messages go up to our brain, and our brain takes a look at them and then it inspects them based on our past behaviors. Have we been in this situation before? What has worked for us before? What's been successful and what hasn't? And then it's going to give us an output. So the output doesn't necessarily have to be pain. It could be inflammation, it could be emotional response, or it could be pain. So pain neural signature. So prior to advancements in imaging studies, it was thought that there was just this pain area of the brain, that when we had pain, this one area of the brain would light up, and that was it. But we now know with advancements in technology that there are multiple areas of the brain lighting up when we have pain experience. So an individual's pain experience is called a pain neurosignature. So it's like their pain map, all areas of the brain that light up when they're experiencing pain. And this makes generalized treatment for chronic pain very difficult because pain is so subjective to each person. So a definition of pain. Pain is a multi-system output activated by an individual's pain map. The map is activated when the brain concludes that the body is in danger and action is required. So knowing some of these things now, we want to progress more towards treating chronic pain with a biopsychosocial model. A true biopsychosocial model is going to include understanding how the nerves process injury and disease, pain, and threat, and how emotions also play into that. So let's get into a little bit of evaluation with chronic pain. So it's with any patient, you want to rule out red flags. You want to do a very thorough eval, but keep it low tech and focus on functional, larger movements. Increase time in the subjective, using motivational interviewing to trying to pull those patients' desires and goals. And I try in my evals to attempt to introduce pain education briefly if the patient is receptive to it and if time allows. Decreasing fear, so just if a patient is very fearful of moving and exercising, teaching them that just because you're hurting doesn't mean we're harming the tissues. And I always try to be as positive as possible, point out the things in their testing that are good and that what's normal, and start to develop that therapeutic alliance. So here's some of the red flags. Typically these are more with acute injuries, but just some things to think about. So cauda equina syndrome, that saddle area numbness, urinary retention, incontinence, difficulty with bladder control, symptoms that are more severe at night and would get worse when lying down, if there's any significant trauma, weight loss, history of cancer, fever, and use of intravenous drugs or steroids in patients over 50 years of age. So what the course was saying here too is a lot of the PTs that were in this course were already doing direct access, so these people should have some type of physician evaluation if any of these signs are present, which I know that we're not quite there yet. Okay, so what central sensitization looks like. So central sensitization is when we're just getting constant input from the periphery. So even things like light touch, warmth, should they cause a pain experience, which typically would be non-painful stimuli. So when they come in the clinic, they typically typically occurs after an injury has healed. They have a lack of consistency to stimulus or response. Sometimes something hurts, sometimes it doesn't. Spreading pain, and these are the patients where maybe you start with the shoulder, now their elbow hurts, now it's the other shoulder, now it's their neck. Or just in general, everything hurts. I've started using body charts again, so the patient can draw where their pain is, and I've had quite a few pretty full body charts drawn. Pain even without stimulus, pain that is seasonal, pain associated with anxiety and depression. Typically with chronic pain, I've yet to see a patient not have a diagnosis of anxiety or depression with the chronic pain patients. They've had traumatic events, and they've had previous poor responses to treatment. So the yellow flags are the factors that can contribute to long-term disability. So these are the psychosocial factors. So attitudes about pain, so a patient that thinks all that their pain should be gone before they go back to work or start normal activity again. Certain behaviors would be like the extended bed rest, not wanting to get up, sickness behaviors. This is a patient that maybe says that their pain's 13 out of 10 all the time. Reduced sleep quality. Patients with compensation issues, so if they have a lack of incentive to, it's work comp, lack of incentive to return to work, or even with MBA. And typically with work, it's patients who have more manual labor jobs or who are not as satisfied with their position. For diagnosis and treatment, they've had people that have had seen multiple physicians. Maybe you're the 5th therapist they've seen recently. And the same kind of like we talked about, expecting to be fixed. Some patients even get advice from physicians to withdraw from work, which is a difficult barrier to overcome with therapy. And then family members, so maybe family is really frustrated with them because of their lack of participation, or even the opposite, they've kind of overtaken their ADLs for them and they're not doing things for them, or they're doing more things for them and not doing things for themselves. And then the emotions we'll get even more into here, but fear of pain, depression, anxiety, disinterest, a heightened sensation of body awareness. So talking about fear a little bit here, this model shows how an acute injury or I also added threat just because there doesn't have to be an injury to have a pain experience. So when patients are fearful of their situation, their pain, they think the worst, they start to avoid activity, and then that leads to disuse, depression, and disability, and they get caught kind of in this roundabout here. Whereas someone who may be more knowledgeable on their injury or pain doesn't have fear, they confront it, they heal, and they recover. Was this recent study done that anyone in the health profession, and I think it was nurses, physicians, rehab physicians, clinicians especially, were 200 times more likely to return to work than a typical individual that had a car accident. So just because they have a little bit better understanding of healing and injury. And then there's also a study on physical therapists with back pain treating patients with back pain, that they don't typically receive help because they understand the injury, they know the process, they move on and go and recover. So it's showing the importance of having knowledge of pain and injury. Has anybody ever had that patient that before you tell them to do something just grimaces right away? So they're already fearful of moving before you even have them do what you want them to do. So the fear of pain is often worse than the pain itself. So we want to try to decrease fear with educating patients on pain. And I've been asked a lot about this lately on recommendations for doing a pain rating. I know that insurance agencies, there are some requirements, but for our patients with true chronic pain, I try not to ask a pain rating all the time, just because as soon as you start asking them about their pain, they're focused on their pain. One of my recent patients, I hadn't stopped doing this just yet, and I was asking her about her pain and what she would do. She would think about it and turn her arm and rotate it, and then she's like, well, and so then we were just hyper-focused on pain at that point. So always using standardized outcome measures because it shows how much their function is improving. So we want to focus more on an improvement in function versus a decrease in pain. So it's recommended to use the standardized outcome measures every 2 weeks with people with chronic pain to gauge how they're improving. Consider using the visual analog scale, still asking about their pain but not speaking about it, just putting a mark, not really putting a number to it, just to see how you can monitor any improvement there. And as I said before, we're focusing mainly on increasing function. Obviously we want to decrease pain as well, but a lot of the studies showing with pain neuroscience education and these programs, the pain ratings actually aren't decreasing a whole lot, but their function is increasing significantly. And we know with chronic injuries that the healing phase we're already past. So asking chronic pain patients for a pain rating, it doesn't correlate to disease or injury at all. So typically the reports are up and down, and it doesn't clinically really tell us much. So that's why we want to focus on the function. Some other scales to use for chronic pain, the Fear Avoidance Belief Questionnaire. This is just the first snip of it. There's 16 total items. The other items are work-related. So I have been using this with each patient at eval, and I typically do this one at eval, progress note, and discharge. And then I'm also choosing a standardized assessment based on the area of injury. So this one is the pain catastrophization scale. It's to identify maladaptive beliefs. If have a patient who you can identify those yellow flags pretty quickly, this would be a good scale to use with them. Okay, so how we can actually increase fear in our patients. This is one of the biggest takeaways that I took from the course. So language and models. Actually, I had to claim that middle one from our clinic with the disc just hanging out on the edge there. And it's hard to see, but the top one, it says normal and herniated disc, then disc degeneration. So it's showing, if we show these to our patients, they already have a diagnosis of degenerative disc disease. Well, I'm abnormal. This is what my disc looks like. Ours here, you can even remove the disc, so they probably think they can bend over and just slip one right out. And then just Google images, any red, the brain is most likely to determine increased pain when you see a red image. So all of our models are pretty provocative in those ways. So I have stopped.
Katie, you had a question?
Yeah.
Do you find that patients respond to this similarly as they respond to the impression on the MRI that says they have three bulging discs?
Yes, and I have a couple slides to talk about MRIs as well. And so especially if you have somebody talking about, well, I have a bulging disc, and you see this red bulge, well, they think, well, that's what my disc looks like. Well, it turns out 40% of people without back pain have a bulging disc. As well as have done multiple studies just to help educate patients on healing for bulging discs. They had patients come in with an acute back injury to the ER, and they did an X-ray, and they saw the bulging disc, and or this imaging study, and I think they came back weekly the next week, then 2 weeks later, and then monthly after that. They're probably glowing, but it showed that by 2 months the disc bulge had decreased by 50%. So we know that even bulging disc will heal. So just to give patients a positive when those things do come up on an MRI, that we know that there are studies showing that these things do heal, tissues do heal. I've stopped talking about anatomy so much, unless I have had a couple patients who are medically oriented that I will use it a little bit with, but still mainly focusing on the nervous system and the brain when discussing pain. And I think it's just a habit that we get into, especially as new clinicians. I was here myself when I was a new outpatient therapist. I felt like I had to talk about the anatomy and the physiology, so patients really felt like I knew what I was doing and that I had a good understanding of the body. And one of the other PTs in the cohort with me, she would say that a lot of new therapists want to flex their PT muscle, so they're showing that they know a lot, but patients don't really get a good grasp on these things. There's not what they're hearing. They're hearing, I have a problem with my tissues when we're doing all these things. Okay, so we know that tissues heal. There's been multiple studies that over and over, we know that the stages of tissue healing are actually pretty predictable. So most tissues are going to heal within 3 to 6 months. Pain lasting longer than normal tissue healing time is more likely due to a sensitive nervous system versus a tissue problem. And just when we are talking about tissue healing with patients, know that we're not disputing that they are hurting. That just because that we know that tissues heal and that their tissues should be healed by the time they come in to see us, it doesn't mean that they're not actually in pain. So we're never disputing that they are making false claims on pain or anything like that, always being compassionate with that, because all pain is real. Okay, so a little bit of this talk about with the MRI, so some normative data for us, and we'll come back to this after I go over a way how I talk to people about pain. So 1 in 3 people over the age of 30 have abnormal findings in the rotator cuff, and this included a full tear. And this is people without pain. And 2 out of 3 over the age of 70, also people without pain, had abnormal disease in the rotator cuff, including a full tear. After successful rotator cuff surgery, if the patient's done rehab, they've regained all their strength and they had reported full function, 90% of those patients still had abnormalities on their MRI and 20% of them still had a rotator cuff tear after the surgery was completed. In people with significant degeneration in their cervical region, on imaging, only 10% experience pain. 90% of asymptomatic people undergoing a cervical MRI have a bulging disc, and this, the youngest included people in their 20s in this study as well. 40% of people with no back pain have bulging discs. In knee and hip studies for you, they, a lot of times, I don't treat the lower extremity a whole lot, a little bit more now with the chronic pain, but they talk about how 1 in 3 professional basketball players have arthritic changes in their knee without pain, and they're able to play basketball professionally. So, and then with the hip, asymptomatic people show 73% of them show abnormalities in the hip, and 69% have labral tears. So, kind of giving some tools to de-educate on the MRIs. So a lot of these things are really scary to patients, but a lot of them can be more normal parts of aging. And when we just have to be careful with this because these are honest and facts, but we want to make sure we're being compassionate with them as well. Okay, so the Pain Neuroscience Education Plus program is based on 4 pillars: pain education, aerobic exercise, goal setting, and sleep hygiene. So without these 4 things in place, they suggest that the patient will most likely not be able to progress with improving pain and function. So I'm just briefly going to talk about aerobic exercise. I know that we all know that there's vast evidence on the benefits of exercise. Instead of treating it, when I talk to people about aerobic exercise, instead of talking about the benefits of the tissues, I talk about other biological benefits like decreasing stress, improving sleep, not just how it affects our tissues. So it doesn't have to be a marathon. The first thing that people look at me when I say aerobic exercise, they think I want them to go run a mile or do cross training or something like that. But starting really small, 1 minute turns into 2, and whatever you want to progress them to. Ideally, with patients with chronic pain, it would be great to do a 20 to 30 minute brisk walk 3 to 4 times a week. So if you want to figure out their VO2 max and the heart rate, you can, but just a simple way to think about, in order to release those endogenous mechanisms with aerobic exercise, we want to increase to at least 100 and 110 beats per minute with what they're doing. So really with our patients with chronic pain, they're typically going to run a little bit higher of a heart rate, so it doesn't take a whole lot of activity to get them up to that. And sometimes with aerobic exercise, I do talk to my patients about the Dallas bed rest study, about how I think it was men in their 20s, bed rest for 3 weeks, and when they were reevaluated 30 years later, the effects of 3 weeks of bed rest was actually worse than 30 years of aging. And all of that was reversed with an exercise program at their 20s. So a little bit about goals. I know we do this frequently as evaluators, but we really just want to not make those generic goals. Patient will be able to complete ADLs without difficulty. Patient will improve shoulder strength to 5 out of 5. Those kind of things. We want to really make sure that the patient has an interest in them. And the pillar of goal setting is not really for us as clinicians, it's for the patients. They have to have some type of motivation, whether it be internal or external, to improve their pain and to get better. And some patients with chronic pain, it is difficult determining what is that motivation. Why do you want to get better? So if I'm struggling at the eval to come up with good goals, and have said this before, I'm a little spoiled. I do get to see all my patients back, so I will have them come back the next session, go home and think about 5 things that they would do if we could flip a switch and they would have less pain. So we start from there. And they're still pretty generic typically, but then we work on breaking those down into short-term goals, the stepping stones, and coming up with a plan for that. I've also started trying to set time-specific goals. Same thing when we kind of think about I want to be able to run this 5K by this date. Like you have a date in mind, you're more motivated. I've had a patient who wanted to be able to cook a meal for family and friends, so they planned to get together on this date. So we had the timeline and worked toward that date. Okay, sleep hygiene, I'll show you guys the handout that I give to patients. This is difficult because most people they look at the list and they're like, I do all these things. I don't go to bed till 1 a.m. I sleep with the TV on. I drink caffeine. And so I usually just have patients try to eliminate 1 to 2 at a time. Start with eliminating one thing. There's a checklist that I'll show here, and let's move from there to try to improve your sleep. So ideally with patients with chronic pain, we would like them to be getting at least 7 hours of sleep. Okay, so a lot of times when I'm talking to therapists about this, when I'm talking about mainly about the education and the psychosocial factors, they say, well, this seems very like psychotherapy. This seems very cognitive behavioral therapy-like. And so my response to that would be that, we're more trying to change patients' cognitions while we're doing the exercise. So it's not like we're just sitting and just talking, where we are talking and retraining their cognitions while completing the activity. And also, we do this all the time. We work on people's cognitions all the time. If you have a surgery that comes in and they're afraid to move, you talk about healing. You show them, hey, this guy just had, look at him on the bike. He just had a knee surgery 2 weeks ago. Look how well he's doing. We are always encouraging patients and trying to retrain their cognition. So it's just that we don't typically do it in regard to pain. So these are a couple of the things that if you're having trouble introducing pain education, so you don't make the patient feel like we're just going to sit here and talk the whole session before we start some of the treatment. Would you like me to explain why you are still hurting? Has anyone ever talked to you about why you hurt? Would you like to know more about why you're still in pain? Just to help introduce the topic. Okay, so this is the story that I use all the time. I'm going to teach it to you with the nail in the foot because that's how I learn, but I sometimes will substitute their injury versus the stepping on a nail if appropriate. So if you step on a nail, you want to know about it, right? And then, so I'm trying to involve the patient in this conversation. And this was a little awkward for me to do at first. It felt a little cheesy, but now that I do it all the time, the patients typically don't think anything of it, and I get some funny answers, and we make some jokes about it later. So, why would you want to know about it?
Infection.
Yeah, get a tetanus shot. One of my patients said so they don't get lockjaw. What came right out of their mouth. I thought that was funny. So you want to know about it to get help. So when we step on a nail, we have 400 nerves in our body, and they're all connected like a highway. All together, all travel up to our brain. And then typically, like I'll kind of reinforce some learning. So how many nerves do we have in our body? And they're all connected, right? And so these nerves, they have a little bit of electricity flowing through them at all times. This is normal. This means that life is good, no threats, we're comfortable. However, if you can see the dotted line up there, there is a threshold that if we go above that threshold, then when we have a threat. So as long as we stay below the threshold, that we are good. So when we step on a nail, our alarm goes off. It goes off because we need to get help. We need to make sure we don't get an infection. It sends a message to our brain, hey, get this nail out of my foot, go get some help. And we try to fix the problem. So eventually we know if anybody's ever stepped on a nail or a tack, it doesn't go away as soon as you pull the nail out of the foot. It takes a little bit of time, but it goes back down to normal. That is how typical healing should go. So our alarm system goes back down to normal, and we're ready for the next threat, to step on the next nail. So the problem is, we now know that in 1 in 4 people, the alarm system, the nervous system, does not calm back down. it comes down, but it stays at this extra sensitive level. And then, so then I typically get here, well, why didn't it calm down? Is the first question. And so those yellow flags that we talked about earlier, the psychosocial factors. These people have had multiple failed treatments, nothing has worked, they've got financial concerns, they've had family concerns, and anxiety and fear. So everything that this person has gone through is going to keeps their alarm system extra sensitive. Dealing with pain adds new stressors to life and work. And treatments have not worked, and you've been given multiple explanations for pain. So multiple different diagnoses, multiple different scans. As long as this patient is stressed and confused and doesn't know why they're in pain, their nervous system is going to remain at this extra sensitive level. Okay, so this is, I made this a year ago, I kind of forgot about that. This is before pain. So you had so much room before your alarm system goes off. You have all this room before you hit the threshold. And now that this is when you hear that, well, I used to be able to run a mile. I used to be able to sit in the car for 4 hours. I used to be able to do this. And now I can only do it. So on the opposite side, after pain, there's so much less room before the nervous system fires, we hit the threshold and we have pain. Make sense? Okay, so this slide is typically where patients can start to see, you know what, my problem is not necessarily a tissue problem, it's a nervous system problem. So this is where I try to move them away from a problem with their back or their shoulder and show them about the nervous system sensitivity. Okay, let's go back to this just really quick. So the 3 questions that people will ask. How do you know? Why hasn't anybody else told me this before? And how do we get it back down? So a lot of times I'll talk about here if typically these patients will be on medications for nervous system sensitivity. So the doc's already kind of told us. They're on the gabapentin, Neurontin, things like that. And then the patient tells us, like we said before, I used to be able to do this, I used to be able to do that, now that you can't. So we'll talk about some ways to calm it back down, but I do typically get the response, well, why hasn't the doctor told me this? Why are you the first person telling me this? So for this education, how should we bill for it? The program has been taught all over the U.S., and there's not been many, at least to the evidence in motion, 8 major issues reported with billing. We have discussed in the program that the best fit would be neuromuscular reeducation, because we are changing the nervous system, which leads to changes in movements, motor control, and function. So changing the cognitions on pain in the nervous system, improving those things. And then when I'm talking about pacing or grading certain activities, sleep hygiene, I'll typically do therapeutic activity for. So the program has typed up a few blurbs of how to document on them and on certain stories and certain things for pain. So I have changed them a little bit, and these are some that I use. So for just the typical, the alarm system metaphor that I just taught you, a patient was provided education on the neurophysiology of pain, being a sensitive alarm system metaphor, to demonstrate pain being contributed to sensitive nervous system versus damaged tissues, education completed to promote deep learning and assist with rehab and recovery. So these will be available on the iDrive if you guys want to go back and look at those. I use the emotions one frequent. These are the most frequent that I use.
A couple are already available.
Yeah,
On our,
I shared them. Yeah. Do we need, how are we doing? Okay.
About like 5 minutes or so.
Okay, let's talk about neurodynamics. Do you have any questions? Go ahead.
Can we include that in the epic?
Yes, I'll share it with you.
Okay, thank you.
Yeah, those 3 are in Epic, and there's a few more as well. into neurodynamics a bit, and then you will talk about another story that I use, and I'll show you some of the other resources that I've been using with patients. This would be more for peripheral sensitization, and I'm just going to talk a little bit about the nerves to help with determining some exercises. So when we have peripheral sensitization, we have changes in the blood supply to nerves, altered ion channel expression, chemical activation, pain and dermatomal or cutaneous distribution, positive neurodynamic testing and palpation, history of nerve pathology or compromise. So these are the patients that come in and almost in the subjective, looks like, smells like, sounds like a nerve. You can pretty much tell, but we're going to do this testing anyway. So we know that the nerves need three things: space, movement, and blood. So when we're focusing on doing treatment with patients with peripheral sensitization, we want to think about the containers of the nerve. So what does that nerve have to move through? What is it surrounded by? Is there scar tissues? Are the muscles tight? And then so we must, before we talk about mobilizing the nerves, we need to think about the containers and make sure that there's enough space for them to move appropriately before completing these exercises. So maybe doing some lateral gliding before we're working on the upper extremity neurodynamics, or traction would be some examples. So nerves need to move. They can move proximally and distally, and even a little bit laterally as well. But they do not respond well to prolonged stretch. So the older neurotension exercises that we know, holding, like the median nerve stretch on the wall, like holding max tension, we know that that now compromises the blood flow. So we're trying to move away from those nerve stretching exercises and just talking more about them as neurodynamic exercises. So they're not really using the term neurotension anymore. And also with knowing that, we have to think about, because how are we taught to stretch a muscle? Low load, prolonged stretching. So whatever movement that we're doing affects nerves. So we really want to make sure, is this a tissue problem or is this a nervous system problem? So some things to look at here, and when you're stretching that person, just remember that low load, prolonged stretch, while it would be great for the muscles, could be cutting off some blood supply to the nervous system. So we know that sustained pressure and stretch can cause vascular compromise and demyelination. So lengthening the nerve just 6 to 8% can start to decrease the blood flow to that area. And there's some studies showing, it's not definite, but the 15 to 20% increase of the length may slow the blood so much that it could be occluded. So we do know, like with the median nerve is quite mobile, it is able to increase by 20% of its length at full tension. So with evaluation for peripheral sensitization, I use nerve palpation. I always start active neurodynamic tests first, especially if the patient's a little fearful, so they're in control of all the movements and see what the results are there. And if they're doing okay, I'll go ahead and do the passive neurodynamic tests. We want to differentiate the structures if it's a nerve versus a soft tissue injury. So if we're looking at the median nerve and we're wondering, well, maybe it's muscular, and then if they do lateral cervical flexion and the symptoms increase, we can contribute to a nerve, because we know that there's no connection all the way from here up to the neck unless it's a nerve besides the nerves. Sorry. Pressure algometry. I don't think any of the clinics have one. But it measures how much force you can tolerate on a point. So we have something that for work comp that measures horizontal force pounds. So I have used that. And just so it's, especially with documentation, it's hard to say, well, like, oh, the patient's less sensitive to touch today. Well, how do you measure that? So with this, you can tell how many horizontal force pounds or how much pressure that they actually can tolerate, and if it's improving or if it's not. And then the use of 2-point discrimination, typically with central sensitization and peripheral sensitization, 2-point discrimination are outside of the norms. So who would benefit from neurodynamics? Individuals with restrictions to neurodynamic movements, active or passive, and individuals who are sensitive to movement in general. Who we should be precautious with. I have used the neurodynamics with central sensitization, but you just have to really think there's a lot to consider with the psychosocial factors, and it's just more complex and more things to think about prior to doing that exercise. You don't want to do it with an acute injury, nerve root disorders, if the patient's had sudden onset of numbness, cord compression, spinal stenosis, osteoporosis, spinal surgery, whiplash, or during growth spurts. Break. So I'm going to show you a couple of videos after the break on how, give some examples on how the neurodynamic exercises look.